ensuring care is inclusive, culturally responsive, and grounded in patient and family perspectives. She's the co-chair of the Patient Needs and Outcomes Committee and helps Fred Hutch define its strategy to identify and eliminate disparities affecting patients, research participants, and the greater community. On Zoom is my friend, Dr. Mandi Pratt-Chapman, professor of medicine at GW School of Medicine and Health Sciences, professor of prevention and community health for the Millikan Institute of Public Health, and associate center director, scientific communications and dissemination for the GW Cancer Center. Her mission is to make evidence-based healthcare and disease prevention strategies available to more people as quickly as possible. She focuses on patient navigation, cancer survivorship, evidence-based cancer control, and health equity for intersectional, lesbian, gay, bisexual, transgender, queer, and intersex communities. And finally, my friend as well, Irene Tamí-Maury from the University of Texas, is a clinician scientist and educator, recognized for multidisciplinary expertise, including dentistry, public health, and behavioral sciences. She's a doctor of dental medicine and has a master of science and doctor of public health, which she uses to bridge gaps between clinical practice and population level health interventions. Her research focuses on tobacco cessation, infectious diseases, including HIV and HPV, and health disparities. So with that said, I have 3 questions. I'm going to throw it out to each, one question to each of the panelists, and then we'll have some conversation around it before moving on. So the first will go to Dr. Chapman. The data, people here may not be familiar with the concept that the LGBTQI population is indeed an underserved population in cancer, from prevention all the way out to end-of-life care. So can you just review quickly the data that supports that statement, that we should consider this community as underserved?
Registries don't currently collect SCHD data, so we can't estimate cancer incidence, survival, or treatment by LGBTI status. We were making progress, pretty significant progress in terms of collecting SCHD or sexual orientation and gender identity in oncology clinics, in EHRs, but that has pretty much come to a stop. There may be some places still doing this, but it's been challenging to advocate for this given our current climate. At state and federal levels. Second, in terms of inclusion in clinical trials, there was a recent abstract at ASCO that noted that just about 6% of cancer clinical trials actually reported sexual orientation and gender identity. So obviously, we're in clinical trials, but we're not counted. So we can't report outcomes or response by sexual orientation or gender identity. Worse, if trials exclude people based on gender or based on criteria that's not driven by the mechanics of the trial record being tested, it's possible that transgender individuals could be excluded from access to trials that they should be able to access. Conversely, if transgender individuals are in a trial, it's really important for us to know differences in response due to hormone exposure and chemical differences from cisgender participants. And of course, there also might be a heteronormative implication in terms of research if in a dyadic study, if that is hetero-exclusive, then also other members of the queer community may not benefit. So with all of that said, even without a lot of data and with lack of comprehensive inclusion in trials, we know that due to targeted marketing and frankly, safety in bar culture, that we have higher alcohol and tobacco use historically, which leads to higher risks for cancer. We have lower cancer screening rates due to gendered clinics and messaging. And what this results results in is a lack of inclusion in clinical guidelines that are really important for cancer screening and treatment management. So yeah, those are kind of the three main things that come to mind.
Do the panelists have anything to add?
No, I think, well, yes, I think that something that is being perhaps not strongly addressed is the fact that the population is out there. It's always been there. And the lack of reporting, as Dr. Chapman mentioned, is making harder to provide the best care for individuals. When you care for someone, you want to know everything of that person, because different behaviors, different exposures, different risk make a difference to prevent, control any condition. So I'm always conflicted by the fact that, oh, it's 9% of the entire population. That is people who report, who are confident on saying, I am part of the queer community. But what about those who don't want to disclose? They belong to that community. They don't necessarily are counted in. So that is the only piece that I wanted to add.
So Mandi, one of the things that just, it struck me recently, and I can't divulge why, but if you think about your medical records for a second, we all capture sex, right? That's a field we have to capture. Do you think people that we work with, administratively, nursing-wise, clinically-wise, do you think they give much thought as to what that means?
Yeah, I mean, I think that we all have mental schemas that kind of default to certain majority group norms, and that it's been really helpful in the past several years to have additional data to make sure that we're providing tailored care for patients. Frankly, and I know this is a bit controversial, I'm a little controversial with myself here, but I'm a little worried about collecting SCHD data in the current environment, and I also still want SCHD data in the current environment because we need it for clinical guideline management. I'm actually going to be working on a study starting in just a few days, trying to better get a pulse on how people are feeling about sharing this information in the current environment, and how to ensure that providers and patients are able to communicate without potentially putting people at risk. I have some serious concerns about just government demands of information and what that might mean in certain contexts. So while I think the data is really, really relevant and important beyond the sex variable, I'm also concerned about basic safety right now and how we can broker those conversations without putting people on a target list.
Yeah, I think the context as well, just for the audience, if you think about how sex is defined in culture today, the government wants female-male. So we can't ask gender questions currently. But if you consider a transgender person, they have a sex that was assigned to them at birth. They have a legal sex, which may have changed if they went to court. They have an administrative sex. And 99%, Mandi, maybe 98% of the time, it's congruent. It's the same. But for that 1 to 2% where it's not, it's a problem. Okay, so I never really thought about that as an issue, but just go back into your own medical records and, really, I think we need to provide some clarity as to what everyone thinks when they look at sex as a variable on the medical record, because having taken care of several gender non-binary people, it's a very complicated issue.
Yeah, and I think too, it's being aware of who your patient is and who your audience is, either as a clinician or a researcher. It can, when you're constantly going uphill and you're constantly facing needing to justify your existence or your gender, it can feel very frustrating when people continue to ask you about binary sex or to demand that you are someone you're not, or misjudge
Thank you. Okay, I'm going to move on to Dr. Tamí-Maury. We know that the LGBTQI community oftentimes faces other disparities, including economic, as well as a history of hostility when it comes to the medical interactions, and that can breed a lack of trust in medicine. You have done a lot of work in smoking prevention, smoking cessation. So I'm wondering, how has your work eliminated those barriers, and also how has it helped you define potential strategies to address them?
Yeah, thank you so much. One of the things that we put a lot of thoughts when we were creating this text messaging smoking cessation program for LGBTQ plus smokers was accessibility, because, and it's kind of going the same line of what Dr. Chapman and Dizon were talking just recently, because the fact that an individual doesn't feel comfortable how other people is addressing this person is a problem, because then people tend to avoid going to care. So I knew when I was designing this smoking cessation intervention, I knew that I needed to, and I was doing a lot of work in with digital platforms and tools. I knew that that could be an approach that helps individuals to still get some care without the need of coming to the facility. And then what type of tool, because not all the tools work, and I wanted to be as, I wanted to reach as many LGBTQ smokers as possible. And I was, at the beginning, more thinking into apps, but apps has a problem, which is the digital divide. Not everybody has the same digital literacy level required to download the app, to install it, so what was the best tool continues to be is text messaging. It reaches out everybody. There is no text message that you don't open. And also for aging population, which now with the shifting of the tobacco landscape, it's important to think that aging population continue to smoke. They are not vapors. So these were the approaches that my team used to kind of elevate accessibility and engagement because it's not just creating a digital tool to provide smoking prevention and cessation, is to think, okay, how sustainable, how will be the engagement over time?
Mm-hmm.
Yeah.
Anything to add, Mandi? Tiffany? No? All right. So let's move on to Tiffany's question, then I'm going to open it up to more frank conversations as well. So Mandi has mentioned it. It's important to Inez's work, Irene's work as well, but the collection of sexual orientation and gender identity was something that we started to do on a national scale. Mandi was actually a co-PI, I believe, on a very large project. And those have sort of been tabled for now, but the work continues. And certainly the work that you've been doing in communication and also access may be informative to that question. So where are we in terms of the ability to collect SCHD? And for this audience, just again, explain the rationale of why that is important.
Great question, and thanks for having me here. I think the reality is it's really going to depend on the state that you live in, and it's going to depend on your institution, and it's really going to depend on the level of safety that patients have at your institution. And then really, as providers, clinicians, and oncologists, the therapeutic relationship and trust that you build with your patients. So there's various different factors and how and when and if you can collect. SCHD data is absolutely vital, especially to patient care. But patients always have a right to disclose and to not disclose. And there's still going to be a balance and a tension that I think institutions and providers are going to have to keep in mind when you're serving patients who are out and there. So I think that's kind of a broader answer. And I can speak, very specifically to Washington State and to Fred Hutch as an institution. Washington State has some, I would just say, a little bit more safeguards. We have a Washington Administrative Code that requires an expanded demographic collection for inpatient discharge data. So, we don't want to wait till someone's inpatient to ask them, what is your sexual orientation? So many hospitals in Washington have done a couple of different things. What Fred Hutch has done is utilize new patient intake in the outpatient setting to collect that. So you're a new patient, and we build trust by communicating very clearly to patients that this information is important to your care. We ask because we care, and you at any time have the right to decline or to share. If you choose to share that information, there is, in the communication we send out, it's only on a needs-to-know basis. HIPAA laws still apply, and you can withdraw that disclosure at any time. So that's in a unique way that Washington is also positioned. We follow various different guidelines, like the NASM recommendations that came out a few years ago, various different literature on best standards to collect this information. And we've done this with both a community-informed way and while working with our patients. We've done a number of different internal SOGI pilots in various different service lines and have reached into what I call a collection cycle process. So we offer this information through the EHR first. So we send out a questionnaire to our patients in the privacy of their device or their portal. They can answer that information. So there really isn't a verbal exchange. And then there are some various different modalities once a patient is in clinic to collect that information. So we utilize the front desk by providing a questionnaire that asks about sexual orientation, your gender identity, sex assigned at birth, and pronouns. And then and patients fill it out if they want to, including decline to disclose, which is considered captured. And then it's the end of that. A patient can always ask to have a private conversation with their providers, and that could be an APP, MD, depending on the service line. So we've created some really patient-centered safeguards by working with patients to say, would you prefer to answer this over the phone? No. Would you prefer to answer this in a private device? Yes. Would you prefer to answer a questionnaire? Yes. And translating those materials to make it as inclusive as possible, as well as engaging with our interpreter services. We hear and serve from patients from all over the country and the world. So patients are often surprised that we ask for SOGI at Fred Hutch specifically. And because we are an academic and an NCI designated cancer center, we do share that the more that we know about you, the more that we can make your care more inclusive and patient-centered. And if there's information that you're willing to share with us that can kind of help the benefit of the larger population for our LGBTQIA patients, we appreciate that disclosure and we'll use that. We've worked with a number of different researchers at Fred Hutch, Dr. Maddie Triplett, Dr. Jamie Hefner, on a SOGI study that they just wrapped up. And we've surveyed patients and clinicians, and patients don't mind in the right setting to answer these questions. But I think it has to be centered on trust, and the federal administration is making this difficult for patients to feel that they can trust their provider and trust their institution. And there's a whole other conversation we can even have for staff education on the topic.
Okay. All right, we have some questions on the floor first, and then I have a very provocative question for the group. Go ahead.
So I'm from Washington State, and we just heard about all the great potential protective mechanisms in place, but probably 6 months ago, front page Seattle Times, Children's Hospital closes their gender clinic. A huge blow. DEI, Fred Hutch closed their DEI program in the very early phase, without much resistance, at the first hint that funding would be suspended or not provided. And so I think this is not just an existential time. People, if they're normal, they should, normal, in quotation marks here, they should not trust our institutions because they're under huge threat. And so all the work that had been done in the last 10, 15 years, and I look at our clinic and the huge accomplishments we did in terms of normalizing bathrooms, respecting pronouns, asking questions in a respectful way. They're not being dismantled, they're still being followed. But as a new person coming to that clinic, I would be very nervous. And I don't know how we get around this in our current environment. And if anyone has thoughts about that, I'd love to hear.
I'll open up to the panel, but I do have, so if you think about what DEI was supposed to accomplish, this is my thoughts on that. DEI efforts were our way of addressing representation and to address disparities. And I think those are two concepts that survive and still go forward in terms of research. I know, Dr. Maury, I'm going to put you on the spot and just discussing how your work, how you've had to adapt into the current funding environment and the challenges that you faced.
Yeah, so for those who have worked with me, I'm part of the resistance in everything. So I'm like,
She means that
it will continue to happen.
Tongue in cheek.
No matter what. And this is not only for colleagues, so I keep saying that to my study participants. I keep telling them, you need to continue participating despite the SCHD not being collected. And we used to, we continue to have with other 3 colleagues an R25 training program that originally was meant for enhancing knowledge and skills in cancer research, focusing on sexual and gender minority population. And we were temporarily terminated, and we managed to bring it back by opening this training for any medically underserved group that also bring in sexual and gender minority groups. Now we're expanding to aging population, rural population, but I am of the people who think that, particularly in certain circumstances, attacking back, I don't think is the option until we continue navigating, but it's just finding ways so we can continue at least doing our best to provide the care that the groups need. So, yeah.
Okay. Mandi?
A couple of thoughts. I kind of surprisingly, a colleague called me the other day and said that they had done some focus groups in a state that maybe people wouldn't feel as safe disclosing, and LGBT individuals indicated in that sample that they really wanted to be seen. In another effort a few weeks ago, I asked for a basic demographic intake for a workshop that I'm doing, and got a very hostile response from someone in the same state that
there's always been that sense of humility, though, with SGM research. We've never said, this is how to do it. We don't have a template. So it's always been going to communities like, can we and how do we? And I think that's probably the way forward even now. Dr. Symington?
Hi, and you are my people, the lady in the red jacket. Just as that gentleman mentioned that you can have first world and third world in every country, I think this question is very geographically different. Our first oath as doctors is to protect and do no harm, and I feel uncomfortable in the state in which I practice, a state where an LGBTQ person 20 years ago was murdered and strapped to a fence. I don't feel comfortable for my patients collecting this information. We are about to stop testing for pregnancy in our treatment patients because some states have ruled that the rights of the fetus outweigh the right of the mother's privacy, so they can subpoena pregnancy test information and use it against the patient and against the service that provided care to that patient. So we're considering not even checking chemo patients for pregnancy anymore because of the political climate we're living in right now.
So, Dr. Simon, I'm going to actually push back just on one thing. I understand the challenges you face to protect your patients by recording, sex and gender. How do you balance their need to be seen?
The state where I practice has a very large closeted population of patients who do not expose themselves in any way.
Yeah.
So sometimes patients will speak to me and ask me not to put it in their medical record, and I accommodate that, but if I ask, I feel like I have to put it in the medical record. And if the medical record, we have states, just as Mandi mentioned, that comply with the Department of Justice and turn over records that they shouldn't be turning over. So I guess I have an imperfect solution to that.
And I think the reason I asked that question is I've started now 2 programs for trans people. It's not a funded thing, it's institutional, but it's called a Bridge program. I started in Rhode Island, actually, Hina. But it's essentially if someone is trans, identifies as trans, and comes into the cancer center, they're meeting me and my team first. We're telling about the cancer center, we're documenting their history, and then we are responsible for the handoffs. As I go to Rad-Onc, as I go to the lung cancer team, as I go to surgery, we're calling that team and prepping them, and saying, this person's coming, these are their pronouns, this is their gender, this is their sex, blah, 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 and this is who they're coming with, so that everyone is aware. And that would not be possible unless we assured them safety.
And what if you cannot?
Right.
What if your own hospital staff mock someone who identifies as they, them?
So I tried to do an implementation project where we did all of that. We questioned everybody at Brown. No one would take the survey. So I think you're onto something. You have a question?
Yeah, thank you. That program, I love that program, but I work at Fred Hutch Cancer Center, and I'm a GU oncologist, so that means that often I get, I've had 2 patients who have, trans women who have found to have testicular cancer after they've had surgery, and both of those patients have written to me in my chart and said, somebody misgendered me, and I felt really uncomfortable and unsafe, and so, I share the struggle. But I want to switch gears a little bit. Again, I'm a GU oncologist. I've had a number of trans women with prostate cancer that I'm treating, and trying to look. And I think that the need for those patients to feel seen is so real to me, and it's hard for me because I can't find any data. Are the hormones safe? I'm giving them Lupron to suppress the testosterone, which is often welcome, but then what happens when we're done with treatment and then the testosterone comes back? I think that is a lot of causing a lot of distress. So one thing I fear is that there's no current data to help me in treatment decision making for these patients, but I worry that there's not going to be because of all of these federal, everything that we're talking about. So I'm curious what the panel has to say about just ensuring that some of these studies get done. What do you guys think? Tips, tricks?
I have a comment.
Please.
Annie. I think, and I've been saying this whenever I get the stage to say it,
Yes.
it's up to the foundations who can provide the money at this moment to have this funding for this conversation for many of us to brainstorm, even with outsiders, on how we can continue doing this work. Because evidently, we cannot apply at this time to any federal funding dedicated to that. But foundations who could have the resources, financial resources, could maybe support a certain workshop or even funding for research that could help a little bit with this gap that is being created.
Mandi?
Also maybe looking at international collaborations or places where there are more current assurances of protection might be important. I also did a study earlier this year that I just wrote up on kind of scientists' experiences in the last year, and then one person I remember said that they had a presentation that they were scheduled to give, and someone saw their poster on the printer and blew the whistle, and they were unable to present that information. So I think that's the danger, and that's kind of what the administration wants, is for us to feel fear and to not be able to trust each other. But I do think it's really important to not assume that, giving information as needed clinically and really looking at the safety protections that are in place, I think are so important.
Yeah, we thought for a while about doing, working with the Broad Institute on collecting tumor samples from transgender people. Can you imagine if we were successful?
Yeah.
That would have been a registry that could have been turned into the federal government.
Exactly.
So I think there are real issues with that. I don't know if we are going to collect that data. We really attempted to do it in the cooperative group system by collecting an expansive data set, and that has been put on ice. And beyond working with LGBTQ community health centers and doing retrospective data reviews using their data in a protected environment, I'm not entirely clear how we're going to do that. Any other comments from anybody? No? Yeah, David?
No, I think the other thing I would just throw out is the challenge in this environment of learning and growing, and how best to really, alluded to treat patients in the room while they're there, as well as the best treatment paths for them. 6 months ago, I saw a person who was a transgender man, but had decided that they wanted to become pregnant. And I was actually seeing him for the pregnancy while he still had a beard. And the disorientation and the way that I fumbled through that process, and I've had years of experience with this, but it was disorienting, because of the biases that we bring into this. And so I think of what, Don, you've done a good job in ASCO, and Ash has had similar presentations these past few years about LGBTQ issues and how best to address patients in the room while we're seeing them, how to navigate these different processes. So there's the federal issues, for sure, the issues of confidentiality, how we collect information, but also really basic education, how we relate to them when we see them.
Right. So we have 5 more minutes left. Oh.
One thing that comes up here that I think is just an obvious point to make is, even if we can't data, we can pay attention to cues and words and mirror those back respectfully. So that is one, alternative, even though it's not perfect, in terms of making sure that we're respectful. The other thing I've been thinking about is shared decision making in terms of if there is potentially a contraindication and there is something that should be considered in terms of treatment, walking through that with the patient and making sure that, having candid conversations and letting them know the risks and benefits. But yeah, we're in a tough spot right now.
Yeah.
Yeah. So Brian Persing, and I'm from Mississippi and also work in Alabama. So obviously one of the areas where it's very difficult to have these sorts of discussions. I think my dad, after my dad died, there was one of his partners that came back and said, we talked about, and this was 11 years ago, how healthcare isn't going in the direction it's supposed to be going in. Everything's going the wrong way. And there was something said that I think we need to kind of think about in medicine again. And this is a discussion that we're having right now, and that is the humanity of what we do when we visit with a patient. And I think the most important thing we do is connect with that patient, okay? Listen to them, listen to their concerns. It doesn't, I know Dr. Symington was concerned about having the chart. It's not in the chart, it's here. I know this patient and I know what they need. And I would love to have a center that we can use to navigate that. Realistically, that's never gonna happen. But I think when we look at medical students coming through medical school, they are very interested in making sure patients receive the care that they deserve. And so I think maybe not a question, but that making sure that we prioritize the humanity of what we're doing when we visit with everybody, and whether it's a difference in ethnicity or whether it's a difference in gender identity, whatever that is, we're treating that individual. And I think we lose sight of that. And no matter what happens, when we close that door, the conversation that we have with that patient is protected.
Yeah. Thank you for that.
I just want to add something because I'm aligned with you in two ways. One, this new generation of people getting trained in medicine, dentistry, public health is totally different. And why do they care? Because many of them are part of the community. If you see the TV shows, there is a queer person represented there. If you, it's out there. So this new generation, these new generations are coming more outspoken and talking freely about their sexuality. So that's why they see the importance. But the other thing is that in my research, kind of aligning with what you do in your practice, what I have included is boxes, and the same as if you ask me, or if the study participants share, I'm having suicidal thoughts, or I have a rash, I keep an open box and I said, you can share everything in that moment with me which you think is relevant, such as blah, 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 sexual orientation, gender identity, and also explaining, in my case in research, the importance of, I'm going to please ask you to repeat that over and over every time we see each other, so you can bring me back to our relationship as an investigator and study participant.
Great. Guana, do you have something to add? One last comment?
Question.
Yeah.
Yeah. So, hi, Guanan here from Yale Cancer Center. So I'm doing research in how we can leverage, technology, AI, in clinical trial designs and also the patient recruitment. So I think this is a very interesting topic. I just want to know for this particular cohort, like anything that you will be recommend that for future, research in this area. I know that, the data collections, right, the gender, is there any restriction in the trial design, exclusion criteria that is strict to that? That will be actually harming, the inclusivity of this cohort. But if there's anything else that you want to add, just want to quick comment. So.
Thank you. It's something to definitely think about. I think we're going to close there, because we have to move on. But thank you so much for joining this session. Hopefully it gave you some food for thought as you navigate the care of this community. Thank you.
Thank you.